Greetings. My name is Pete Van Beek. For the next few minutes, I'll be discussing trauma-related disorders and focus specifically on acute stress disorder, or ASD. We will look at the diagnosing criteria, discuss assessment strategies, and then design and implement a treatment plan. I chose this particular disorder because of my involvement with first responders and others who have been directly exposed to traumatic events that include combat, sexual assaults, violent crimes or domestic violence, sexual harassment, natural disasters such as hurricanes and earthquakes, car accidents, or other events that may include witnessing the shooting, such as mass shootings. The diagnosing criteria for acute stress disorder can be found in the Diagnostic and Statistical Manual version 5, or the DSM-5. Which was published by the American Psychiatric Association in 2013. Page 280 of the DSM-5 lists the diagnostic criteria as 308.3 parentheses F43.0. The essential feature of acute stress disorder is the development of characteristic symptoms lasting from 3 days to 1 month following exposure to one or more traumatic events. Section A of the diagnostic criteria requires that there was exposure to actual or threatened death, serious injury, or sexual violation in one or more of the following ways: directly experiencing the traumatic event, witnessing in person the event as it occurred to others, learning that the event occurred to a close family member or close friend. It's important to note that in cases of actual or threatened death of a family member or friend, the events must have been violent or accidental. Experiencing repeated or extreme exposure to aversive details of the traumatic event. In addition to the criteria in Section A, there must be the presence of 9 or more of the following symptoms from any of the 5 categories of intrusion, negative mood, dissociation, avoidance, and arousal, beginning or worsening after the traumatic event occurred. Intrusion symptoms include recurrent, involuntary, and intrusive distressing memories of the traumatic event. Recurrent, distressing dreams in which the content or effect of the dream are related to the event. Dissociative reactions or flashbacks where the individual feels or acts as if the traumatic event was happening again. Number 4, intense or prolonged psychological distress or marked physiological reactions in response to internal or external cues that symbolize or resemble an aspect of the traumatic event. Negative mood would be the next category and include the persistent inability to experience positive emotions such as happiness, satisfaction, or loving feelings. Dissociative symptoms are seen when there is an altered sense of the reality of one's surroundings or oneself, such as being in a daze or feeling that time is slowing. The inability to remember an important aspect of the event, which could include dissociative amnesia, but not other factors such as head injury, alcohol, or drug use. Avoidance symptoms include efforts to avoid distressing memories, thoughts or feelings about the traumatic event, efforts to avoid external reminders that include people, places, activities, or situations that arouse distressing memories, thoughts, or feelings closely related to the event. And finally, arousal symptoms that would include sleep disturbance such as difficulty falling asleep or staying asleep, irritable behavior or anger outbursts with little or no provocation, hypervigilance, problems concentrating, and an exaggerated startle response. Remember that the presence of 9 or more symptoms from any of the 5 categories we just discussed must be present to meet the diagnostic criteria. Criterion C states that to meet the criteria for acute stress disorder, the duration of the disturbance symptoms we just heard in Criterion B is 3 days and up to 1 month after trauma exposure. Criterion D states that the disturbance causes significant distress or impairment in social, occupational, or other important areas of functioning. And finally, Criterion E, where the disturbance is not attributable to the physiological effects of a substance such as medication or alcohol or other medical condition, and it can't be explained better by brief psychotic disorder. When we discuss assessment strategies, we understand that the clinical presentation of acute stress disorder will be different for each individual, but will typically involve an anxiety response that will include some form of re-experiencing or reaction to the traumatic event. Dissociative symptoms are common during traumatic events, yet only those lasting beyond 3 days are considered for a diagnosis of ASD. Alterations in awareness can include depersonalization, which is a sense of feeling detached from oneself. Avoidance of stimuli is evidenced as the person may refuse to talk about the experience or engage in avoidance strategies in an effort to minimize the awareness of the emotional reactions. It's also very common for the person with acute stress disorder to experience difficulties falling asleep or staying asleep, which may be the result of nightmares or a heightened level of arousal that keeps them from sleeping. Now we'll discuss the principles of selecting a treatment plan. Consideration should be given to the patient's culture, gender, age, history of previous traumatic experiences, substance abuse, developmental history, and psychiatric diagnosis that they've had, as well as the current potential for aggression and/or self-harm. Although medications are commonly used in the treatment of ASD, in the book Understanding Abnormal Behavior, the authors suggest that prolonged exposure therapy, or PE, cognitive behavioral therapy, CBT, and eye movement desensitization and reprocessing, EMDR, are more effective in treating ASD and PTSD than other psychotherapies. They also state that ASD patients can be helped with CBT that incorporates exposure therapy. The goal of any treatment approach is to reduce the patient's overall level of emotional distress, as well as assist in the reduction of specific target symptoms that would impair social or occupational function. Generally speaking, the therapist will assist the patient to manage and tolerate the immediate distress of the memories involved with the traumatic experience, which should lead to a decrease in distress over time. During therapy, the therapist will work with the patient to enhance their ability to discriminate the trauma cues and reminders from the traumatic event. This is accomplished by promoting coping with re-experiencing and helping promote the belief that their current response to triggers is a result of a past danger that is no longer present. Since ASD by definition occurs within 4 weeks following a traumatic event, treatment during this time frame should also be considered as a preventive strategy for PTSD. As a result of my research into this disorder, I am left with a higher level of comfort to assess, diagnose, and determine the proper treatment intervention for acute stress disorder. I've also developed a higher level of comfort navigating through the DSM-5. With proper assessment and treatment, those suffering from ASD can begin to work through the painful memories that have disrupted their lives, occupation, relationships, and everyday normal social activities. Patients will never forget the traumatic event, but they can learn coping techniques that will help them realize that the event was in the past and does not present a current danger. Thank you.